Hello guys, this is Vikrant Sengar, pursuing MBBS from GRMC Gwalior, now presenting a beautiful lecture on the great topic, that is the Achalasia Cardia Part 2. So let's get started. So guys, I have posted my notes on my Instagram account, that is the Integrated MEDICOZ. Do check it out for the integrated respective notes here. Right, so we have discussed the part 1 of Achalasia Cardia in our last video, and today we will concern about the part 2 of Achalasia. In the part 1 we have covered the anatomy, physiology and etiopathogenesis, clinical features and the complications of Achalasia Cardia, but now in this case we will go for the diagnosis and the management. That is the diagnosis, right, and this portion, that is the treatment here. Right, and in the case of the diagnosis, we will go for the manometry and the high resolution manometry. And as we have discussed the high resolution manometry in our last video, do check it out for the more details here. Right, followed by the Chicago classification, and we have discussed this classification earlier, but now we will discuss as well. But that is the diagnosis. Followed by, we will go for the management section, that is the drugs, followed by the endoscopic procedures and the laparoscopic procedures, and the most important thing, that is the notes. Example of this is the poem. So guys, this is what the overview is, and now we will go for the diagnosis of Achalasia Cardia here. And number one thing is the Chicago classification here. In early Chicago classification, only plain manometry is used. The esophageal manometry is used, and the criteria for the esophageal manometry was the three. Okay, number one is the failure of relaxation of the LES, right, the LES here. And second criteria is the ineffective contractions of the body of esophagus here, so that the peristalsis is not evident and that is more commonly dilated because of the lodgement of foodstuffs. Third criteria is the pressure of LES, that is more than 26 mmHg here. Right, so this is what the basic three criteria with respect to the Achalasia Cardia in the previous version of Chicago classification. But now in the case of the latest version of Chicago classification, that is version 3 of Chicago, we have involved the new modality, that is the high resolution esophageal manometry, and this session over the HRM has been discussed in my last video. Do check it out for the great details there. So guys, what is the IRP? The first term is the IRP, the integrated relaxation pressure here. Okay, so in the case of the esophageal pressure topography, what do is we need to take a time segment of 10 seconds, right? And we need to pick the 4 seconds out of those 10 seconds where the relaxation is maximum after deglutition. Okay, those time segments of 4-second duration we need to pick at which the relaxation is maximum. So relaxation is maximum after deglutition, and we need to take the average of those 4 seconds, and if the value is less than 15 mmHg, that means condition is normal, IRP is normal, right? And whenever the value is more than 15 mmHg, that means IRP is abnormal, elevated, and that is the criteria for the achalasia that is common in the class 1, class 2, class 3. All the classes of the Achalasia Cardia are just having the same criteria with respect to IRP, that is more than 15 mmHg value of IRP there. Done. Followed by second term, that is the DCI, that is distal contractile integral, right? So we have discussed there a point of transition, right? A point of transition is there between the upper part, that is the skeletal muscles of esophagus, and the distal part, that is the smooth muscles of esophagus there, right? So between these two smooth muscles and the skeletal muscles of esophagus, we are having a transition zone between. Okay, so distal to this transition zone, we will measure the strength of contraction of esophagus, right? And the normally we are just having 450 to 8000 mmHg seconds centimeter value of the esophageal contraction in the case of normal persons. If it is more, esophagus is hypercontractile. If it is lesser, then esophagus is hypocontractile. So third term is the CDP. Okay, the CDP here, right? And that is the contractile deceleration point, right? This is the point of turn in esophagus, or the turning point of esophagus, after which, right, after which the peristalsis is not needed to propulse the food, the gravity is enough, right? So before this CDP, the peristalsis is needed to push the food material. So a point called as CDP in the esophagus, after which peristalsis is not needed to propulse the food, rather the gravity is sufficient to pull the food to the stomach here. That is CDP. And fourth term is the distal latency, DL. DL is, this is the time duration between the opening of upper esophageal sphincter to the CDP. Normally it should be less than 4.5 seconds, and if it is more than 4.5 seconds, that is the pathology, that is abnormal, and that is the class 3 achalasia cardia there, right? And all these things we will discuss in this video as well subsequently, but now we will go for the modified or version 3 Chicago classification, and this classification have also been discussed in my last video. Do check it out for great details there, right? In this classification we have 3 classes there, right? Class 1, class 2, class 3. Class 1 is called as the classical achalasia, class 2 is pan-esophageal compression or pan-esophageal pressurization, right? And third class is the spastic achalasia there, right? And what is the common thing among the 3 classes? First point, that is the mean IRP value that is common, which is more than 15 mm Hg in all the 3 cases there, right? This is the common value. So this is the first term. Second term is DCI, right? DCI in the case of class 1 achalasia, that is less than 100. That means esophagus is not having power for the peristalsis. Esophagus के पास इतनी power ही नहीं है कि वो peristalsis continue कर पाए. Contractions occurring inside the esophagus distal to transition point is not sufficient to propulse the food here, right? So that is called as the failed peristalsis. That is the 100% failed peristalsis. Peristalsis हो ही नहीं सकती क्योंकि esophagus के पास power नहीं है propulse करने के लिए food bolus को, right? So that is what the DCI is. Third term is the DL, right? And DL is normal, right? That is less than 4.5 seconds, right? In the normal personalities, we are having the same value, that is less than 4.5, and in the case of class 1, which is also normal here, abnormal DL is present in the class 3 achalasia, that is more than 4.5 seconds, that is the abnormal one, right? And second term is the pan-esophageal pressurization. The whole esophagus is that pressurized as the DCI can be measured. So due to the pan-esophageal pressurization, the peristalsis can't occur inside the body of esophagus. That's why the peristalsis is also failed in the class 2 as well. In the class 3, we are having the spastic contractions occurring, right? And the DCI, the strength of contraction, is moderate, is not being lesser as less than 100 in the case of class 1. That is normal. That is more than 450 mm, which is normal value. But the spasms are occurring. The normal peristalsis is not present, so no normal peristalsis. No normal peristalsis is there. Spasms are occurring here and no normal peristalsis because of the spasms, and the DCI, the strength of contraction, is normal because of the spasms. But this is not normal because of the absence of peristalsis here as well. Done. This is what the modified Chicago classification of version 3 Chicago classification. So guys, we will go for the radiodiagnosis of achalasia cardia here, and we have to go for the barium swallow. The whole esophagus is being stained, is being radiopaque, and after this we will go for the x-rays, and we will find there is a gradual tapering here, right? The gradual tapering of lower end of esophagus is being seen, and in the form of the bird beak appearance here. So bird beak appearance like that. So gradual tapering is there, right? So this is the gradual tapering in the form of bird beak appearance, right? So if there is sudden tapering like this of lower end of esophagus with the shouldering present, that is the sign of the malignancy there. Okay, so rat tailing with or without shouldering, that is the sign of esophageal carcinoma. And when we find the apple core appearance, that becomes more aberrant. So guys, once we have done with respect to the radiodiagnosis and the diagnosis of achalasia, we will go for the management of achalasia cardia there, right? The first line of management is the drugs such as CCBs and nitrates. Okay, so we will first discuss CCBs. The mechanism is that these drugs are just causing the blockade of calcium channels, so the smooth muscles are relaxing here. So relaxation of smooth muscles of the LES is achieved with it. So the examples include the dihydropyridines here. So nifedipine and amlodipine are the examples of that. And the uses include the angina, hypertension, and achalasia cardia here. And the side effects include the palpitations, flushing, and the ankle edema there, right? This is first category of drugs, followed by the nitrates here. The mechanism include, okay, so this is the nitrate, and that is first broken down to the nitric oxide here, and this nitric oxide stimulates the cyclic GMP, and that in turn stimulates the protein kinase G, okay, and which dephosphorylates MLCK, right? So MLCK is dephosphorylated, and this is the main guy for the cause of contraction of smooth muscles, and once it is inactivated, the muscle is being relaxed here. This is the mechanism here. And now examples include isosorbide dinitrate and the nitroglycerine. The examples of that uses include the same as above: the angina, hypertension, CHF, the congestive heart failure, and the achalasia cardia there. And the side effects include the flushing, postural hypertension, dizziness, tolerance, and dependence to these nitrates, right? And once the medications are refractory, we will go for the endoscopic procedures. So the endoscopy guided Botox injection or the endoscopy guided bougie or balloon dilatation is there. But in the case of Botox injections, the frequency of recurrence is higher, right? When the drug vanishes, when this toxin vanishes, the symptoms again appear. And in the case of the bougie dilatation or the balloon dilatation, the risk of getting perforation is there. And once we have discussed the endoscopic procedures, we will move to the laparoscopic ones. The laparoscopic procedure, that is the laparoscopic Heller's cardiomyotomy. So in this case, we need to go for the myotomy. The circular muscles are being cut here, right? So the extension is from the 5 centimeter proximal. This is the gastroesophageal junction. Okay, so we need to go for the 5 centimeter proximal, right, and 2 centimeter distal to the gastroesophageal junction to go for the myotomy. That's why the process called as the Heller's cardiomyotomy, since it is extended to the cardiac portion of the stomach here. So after cutting the smooth muscles, the smooth circular muscles of esophagus, we need to go for the fundoplication. That's why this is the area of fundus, okay, and that is wrapped around this portion so that reflux is not being the complications of this surgery. So we are just having two methods. Either we will go for the door or the toupee, right? Door is the anterior 180-degree wrap of fundus over the esophagus, right? And toupee is 270-degree posterior wrap of fundus over the esophagus. And once we have discussed the laparoscopic procedure, we will go for the nodes. Nodes is the natural orifice transluminal endoscopic surgeries, and one of the examples of this is the poem, right? This is the peroral endoscopic myotomy. So this is guided with upper GI endoscopy, and we need to go for the cutting of muscles via the endoscopic procedure, and we need to first enter to the mucosa. So inside the mucosa we need to enter here, right, and followed by we make a tunnel inside the mucosa, right? So that is the tunnel inside the mucosa, and followed by we need to go for the removal of circular muscles. These are the circular muscles and we will cut it. So the removal of the circular smooth muscles are there, and followed by we need to place a clip there to tie up and to repair up the mucosa, and then we remove this instrument along with the upper GI endoscopy, right? So this is it with respect to the management of achalasia cardia, and thank you for watching. So guys, if you're just having any doubt or inquiry, you can go for the comment section below, hit the like button for the sake of the motivation, and don't forget to subscribe. Pressing the icon will give me some vibe. So we will meet at the another section of disease, that is the gastroesophageal reflux disease. So till then, keep integrating. Thank you.